Good evening. My name is Barsha Mondal, and I am a part-time lecturer in the Department of English, Rabindra Bharati University, Center for Distance and Online Learning, Kolkata. I welcome you to the stories of tribal identity and culture that will explore how tribal history plays a pivotal role in history in shaping cultural identity and ideology, curated under TMYS Review December 2024 in collaboration with the Center for Asia Pacific Initiatives, University of Victoria. We are also calling for submissions of essays, poems, and short stories under the project. To know more about the submission, guidelines, and project architecture, please visit www.tellmeyourstory.biz. This evening, I will be concentrating on the tribal identity and culture shaped by tribal historians and historians, Professor Nemthianngai Joshi, Dr. Nabin Kumar Dhal, and Dr. Nadeen Pakyntein, who will be joining us shortly. The topic for today's discussion is role of environmental consciousness in cross-culturalization. Before we begin, I would like to introduce our speakers. Our first speaker for the session is Professor Nemthianngai Guite. Dr. Nemthianngai is an associate professor in the Center for Social Medicine and Community Health, School of Social Sciences, Jawaharlal Nehru University of Delhi. She is engaged in teaching and research supervision of MA in Public Health, MPhil and PhD program in the center. She holds a master's degree in social work from Delhi University and a PhD in social medicine and community health from JNU. Her academic research engagements are on social science approaches and perspectives towards healthcare, plurality, and system of medicine, including knowledge and practices on modern, indigenous, traditional, complementary, alternative, or integrative medicine. She has authored the books Indigenous Medicine and Healthcare, a study among the Paitha tribe in Manipur 2011, and Global Discourse and Local Realities Towards Indigenous Medicine 2014. Apart from this, she has also presented papers, national and international conferences, and published in peer-reviewed journals on primary health and indigenous medicine, indigenous health healing systems, indigenous medical knowledge, maternal and child health, and health issues, and others. We are delighted to have you on the panel, Dr. Guite. Thank you for joining us this evening. Our second speaker for the session is Professor P.C. Joshi. Professor P.C. Joshi, BSc Honours, MSc, MPhil, PhD in Medicinal Anthropology, Delhi University, is a former Pro Vice Chancellor and officiating Vice Chancellor of the University of Delhi. He has been the head of the Department in Anthropology in the University of Delhi and a prominent external expert with Indian Council of Social Science Research, University Grants Commission, Ministry of Tribal Affairs, Department of Biotechnology, and associated with universities like Tirupati, Vidyasagar, Calcutta, and others, and involved with teaching or research with Heidelberg University, Germany, Catholic University of Louvain, Belgium, Xavier's University, Philippines, and others. He has organized 15 conferences, including one in University of Hue, Vietnam, in the year 2010. He is the current president of Society for Indian Medicinal Anthropology, Mysore, vice president of United Indian Anthropological Forum, and project advisory of the Indian Gandhi National Center for Arts, Ministry of Culture. He specializes in the field of medical anthropology, Himalayan anthropology, antibiotic resistance, and qualitative research methods, and has more than 150 research articles and more than 10 books to his credit. It is a pleasure to have you with us today, Professor Joshi. Thank you for joining us this evening. Our third speaker for the session is Dr. Nabin Kumar Dhal. Dr. Nabin Kumar Dhal earned a PhD in Floristic and Ethnobotanical Studies of Nabor district from Utkal University. He has research experience of 33 years as Chief Scientist in Environmental and Sustainability Department of CSIR, Institute of Minerals and Material Technology, Bhubaneswar, and looking for the exploration of natural resources of Odisha, biodiversity conservation, ethnobotany, antimicrobial activities, phytochemical screening of medicinal plants, and others. He has published 222 research papers in different national and international conferences and handled 37 research projects funded by different funding agencies. He has reported the concurrence of Coralodiscus battling a new generic record for Eastern Ghats, Odisha, in current science and published books entitled A Pictorial Guide to Ferns of Similgul, Trees of Chandaka Wildlife Sanctuary. He is a fellow of Society of Ethnobotany, Indian Association for Angiospermic Taxonomy, National Environmentalist Association, and fellow of International Society of Environmental Botanists. A very warm welcome to you, Dr. Dhal. Thank you for joining us
Yeah.
this evening. Our fourth speaker for the session is Dr. Nadeen Pakyntein. Dr. Nadeen Pakyntein is the Associate Dean of Students in Martin Luther Christian University. She is an academician who is still looking to grow professionally. She has worked on the creation of a curriculum on the health of indigenous and tribal communities, funded by I'm sorry, Rosa Luxemburg. Stiftung, Germany, and has hand-on experience in the creation of a training manual for foster parents in Meghalaya, funded by SOS Children's Village. A very warm welcome to you, Dr. Pakyntein. Thank you for joining us. We will now move on we will now open the forum for discussion. I would request Dr. Guite to share her insights. Ma'am, over to you now.
Thank you, Barsha, for giving me the first opportunity to share my insights into the topic, which is on medicine, health, and wellness, eco-conscious tribal manufacturers. Though I am a little uncomfortable with the term tribal manufacturers in the sense because I have not any direct kind of, when I see the term as manufacturer, so either manufacturer of knowledge or manufacturers of either any kind of startup or enterprising something in the field of uh, eco-conscious initiatives or activities. Uh, Nevertheless, I would like to just share my insight into the topics and then the kind of work as you have introduced me kindly in terms of the kind of work which I have done, research work, and the engagement has been, I would say, if I go back since my as I complete my master's degree, so I had an opportunity to work with uh, in the field of medicinal plants, trade, conservation, and all research, which was part of my internship to do the masters to complete the master program. So uh, that was the first, I would say, my first intersection with in this larger field of medicinal plants and indigenous medicinal knowledge, and then from there on my interest grew, and then I contemplate on doing academic studies and research into this field. So that first interface was with in Uttarakhand state in the district of Pithoragarh. So there I was engaged in research project funded by WWI Wildlife Institute, and it
Mhm.
was looking into the conservation, cultivation, preservation, and promotion and protection of medicinal knowledge, and then up of all the healers and all those things. So that that interface gave me an opportunity to engage in my MPhil and PhD research. And I, being from Manipur, one of the states of the northeastern region, so thought that doing this from a public health perspective. So when we look into the kind of health problems and the kind of many unanswerable disease pattern which is coming up, and where we see that medicine is not only the solution to all the health problems that we are facing in India right now, and at the same time when we talk about wellness, health, it's not only about medicine. There I see the difference of, like, when we talk about healthcare and medicine. So care is more about maintaining, and care is more about healing. And then a caregiver can be not necessarily a person who is trained in formal medical institute. A person can be informally trained also through one's own experience. So that kind of caregiver and healers that you see in the northeastern region is one because of the rich biodiversity hotspot. And it's one of the six biodiversity hotspot in the world, and also the absence of modern health services, the biomedicine. Because biomedicine is something where the state has given a strong patronage, and a lot of investment has been done, and budget allocation is done on biomedicine as compared to the local health traditions. But at the same time, local health tradition has been able to uh, cater to the primary basic healthcare needs of the people in maintaining their health in preventive measures. So the curative services, when we talk about diagnostic and then curative in times of emergency, and when things has gone out of hand, when it cannot be prevented anymore, then biomedicines comes handy. But when we see the larger population in the northeastern region, we see that there is lack of resources when it comes to health service delivery and infrastructure. So that's where the challenge lies. So this in that situation, the only thing which I see as a at this contemporary times, when we are struggling with most of the chronic diseases, for example cancer or cardiovascular diseases and many other things. So it's very important to strengthen this knowledge, and then it's very important to profile the healers, or let's say the local health tradition practitioners, and strengthen them and train them so that the best potential is realized through this. And at the same time, uh, given the global discourse, when it comes to the World Trade Organizations coming into the TRIPS agreement, and you have your intellectual property rights, which talks about patenting of knowledge which are in private domain, and there is an issue of private domain and public domain, and you have trade advocates who wanted to kind of uh, capitalize those resources. So you see there is a lot of biopiracy going on in terms of knowledge, in terms of the herbs and the plants. So there are various challenges when it comes to TRIPS agreement and the intellectual property rights. So one can always, because India being a signatory to the TRIPS agreement, so there is a very little chance to get away from it. And what I see through my research and other researcher also, that one is that we can use this IPR as a tool for economic development, for livelihood, and also at the same time to address the healthcare needs of the people over there. So there are various other stakeholders we can see at these modern times, like you have the drug companies, the pharmaceutical companies, and then we just have to see that there is a benefit sharing, and then the healers or the knowledge holders, they should not be exploited. So there has to be a strong strong support from the government, and there has to be a strong policy towards that. So I think a political strong political will to give patronage to the local health traditions of the tribal communities is very important. And one last conclusion I want to say: tribes as such in India have very inter and intra, distinct characteristics. Tribes of northeastern region and tribes of the central India or the northern or the south all have different, cultural traits and its own characteristics. So sometimes we cannot just see as one entity when we talk about tribes in India. So that has to be keep in mind when we talk about the larger issue, which is when we talk about tribal health or when we talk about political identity which the tribal people are facing. So so all those things needs to be taken into consideration. So I think I would end my opening remarks with this. Thank you so much.
Thank you for your valuable insights, ma'am. Every tribe actually has very different characteristics and healing traditions. We cannot actually gather them together under one umbrella. Thank you so much. Our next speaker for the session is Professor PC Joshi. Over to you, sir.
Okay, thank you very much. I first of all would like to congratulate you all for thinking of tribal health, tribal medicines, which I personally feel is a very neglected area in India. But at the same time, looking at from the point of view of market and manufacturing, is a very, very potential area. Now, I would like to talk about India first. Well, in Mahabharata, it is said that what is found in India can be seen elsewhere, but what is not in India cannot be seen elsewhere. Yad hasti tad anyatra yan hasti natat kvachit. So this is true of Mahabharata, but this is also true of Bharata, that is our country. We have a very, very unique country in the world, which is a very diverse country. But diversity alone is not what defines India. What defines India is there is a continuity in civilization. For the last 5,000 years, there is a continuity without any break, and nowhere else you will see. And therefore, whatever we have, whatever heritage we have, particularly if we are talking of herbal medicine or medicinal heritage, it is a very rich heritage. It is uninterrupted heritage that we have. And if from that point of view, I think we need to understand India and the potentials of herbal market, potentials of tribal manufacturers. In this sense, we have to see. Nowhere else in the world you will see that kind of a opportunity, that kind of a potential. Secondly, the India, we can say that there is a three-tier system that we have in India. Now, two tiers are very well known. First tier is, of course, what is called as allopathic medicines, biomedicines, the scientific MBBS kind of medicines that we have. Very, very popular, very, very efficient, and widespread all over India. You can see that. Second is a classical, we have got, second is a classical kind of regional systems that we have. What is called, what you can say again, is the Ayush. This could be the second area. Ayurveda, Siddha, Unani. This is the second layer that we have, which has its origin mostly in India, but also in also in Arabian countries or maybe in Germany for some conditions. Some of these like Unani, like homeopathy, like naturopathy, which has come from outside, but they are all now part of Ayush. But there is a third level which is not much understood. Now that is what is called as local systems. There are not less than 4,600 different kinds of such local systems that exist in India, and their potentials actually are not known, not much known, and only I think to some extent I think anthropologists have been working to investigate, to understand those systems of medicines. Now, what are these local systems of medicines? I would say, first of all, they are not bits of some herbal medicines or some of these numbo jumbos. They are medical systems per se, which means they have a full fledged curative system, they have a full fledged preventive system, they have a full fledged diagnostic system, and they have a full fledged promotive system. So, health promotion, health curative, diagnostic, and preventive, all systems are very, very well defined. Now, there are two basic divisions in these systems that we can see. One is empirical based system, where it is the empirical evidence, it is the herbs and all those things that define the diseases. It is also called as natural, natural theory that we have. Another is where it is no is super empirical, which is magico religious, and these are, we have to understand them from this point of view. This latter one is where most of the ethno-psychiatric things are taking place. Now, this system is, generally it is, like we don't pay much attention to this system. But we must understand, as I said, that India is a very, very, is a country with a continuity. Similarly, this particular system also has a very, very historical continuity. It is based on experience. It is based on hit and trial people have been doing for generations together, and then they have come out with this ethno-medicinal knowledge that they have. Now, one thing that I think this system can tell us, you see, we say that health is not only physical but is also social. But I think this social aspect of health, the socialness of the health, is very less understood, even in allopathy or even in this biomedicine. Even in, I would say, even Ayurveda, it is not very well understood. But these systems, that local systems that we have, they have very strong, very strong social health aspect. And this social health aspect is something that I think others have to emulate. Because what is happening, if you look into the textbooks of the allopathic medicines or even other psychology, clinical psychology, you will find that they are basically based on the Western society, the American or Euro-American society. They have taken the model of American Euro society, and then they are trying to use their therapies in India based on that model. Although India, socially speaking, culturally speaking, India is a very, very different country, different culture altogether. I say India is a we culture, and we culture as against I culture of the West or Euro American I culture.
Professor Joshi, you have been locked out, I guess, from the screen. She joins us back. So, please, over to you now. Sir, Dr. Nabin Kumar Dhal, can you hear me?
Yeah, I'm hearing. Am
Sir,
I audible?
sir, please take over. Yes, sir, you are audible.
Audible. So,
Yes, sir.
good evening, all. Our respected, esteemed panelist member, Professor P.C. Joshi, sir, Professor Guite, ma'am, and Dr. Nadeen, ma'am. And thank you, Barsha, for giving this opportunity. You told me to prepare some PPT. I have prepared some PPT based on our case study. Is it possible to show you the PPT?
Yes, sir. Yes, sir.
Eh?
Yes, sir.
Yeah,
It
how
is.
I will show you.
Uh, I have again come.
Yeah,
Is my
please.
time over?
No. Yeah,
Present.
please.
There is a
Oh, I'm
Yeah,
sorry, there was no light. In
yeah,
India,
yeah.
you have this problem.
Yes.
So what I was trying to tell you, may I continue now?
Professor,
May I continue?
Professor Dhal, Professor
Yeah,
Joshi, uh,
Yes.
Professor Dhal, could you wait a bit? Let Professor Joshi complete the entire thing,
yes.
and then we will. Okay, sir. Thank
Mhm.
you so much. Sir, you
Yeah,
can continue.
Okay,
Joshi
I'll
sir,
take
please
few
continue.
more minutes now. So I was telling about I culture versus we culture. if you go to America, you'll always be known by your first name. Nobody would know your surname. That is what is I culture. I mean, you are your privacy. Everything is important. Individual is important. The group is not important. In India, it is the group which is important, and privacy has no meaning in India. Therefore, we are known by Professor Joshi or Mondal or whatever. Our surnames. We are not known by our own name, but we are known by our surname. That is what is like the social fabric that we have in India. In India, we have no privacy. In India, the guest is called Atithi, means somebody who goes unannounced. This is not heard of in American context. You can never heard of a guest coming unannounced. You have to take an appointment, and even if you have to meet your parents, you have to take appointment. That is what is the kind of culture. Now that model of social model has been like used in the textbook that we have in India because they are influenced. So therefore, what I'm trying to say is that if you want to understand social health, we'll have to understand Indian society, Indian social fabric, and use that in health, and that would be a better. I think these traditional societies are very good as far as the social aspect of health is concerned. There is something which we have to learn from them. Finally, what I would like to tell you, you have talked of manufacture. And now in India, after independence, there have been two stages that I can identify. One is called medicalization, where the Western medicine or the biomedicine or the allopathic medicine was superior, and it was treating all other medicines as inferior. But I think after 80s, when we have Ayush, Indian system of medicine, homeopathy coming into picture, we had a resurgence, an empowerment of Ayush, at least the Ayurveda, Unani, and there has been an empowerment of them. Now they have become strong. There is now a separate ministry for them. They are not no more affiliated with our ministry. They are a separate ministry in themselves. Now what is happening? That now Ayush has become very powerful, but Ayush has become powerful at the cost of local medicines, tribal medicines. Now I give an example. So what is happening today? It is, I call it Ayushization. The tribal medicines, the local medicines are also Ayushized. So a good example could be Pasighat. We had National Institute of Folk Medicine. Now National Institute of Folk Medicine basically was to strengthen and empower the tribal medicine. But what has happened? It has now become National Institute of Ayurveda and Folk Medicine. So folk medicines have now been affixed to Ayurveda. So they have again become a part and parcel of Ayurveda. I would say that they are a system which again 5,000 6,000 old systems, very rich heritage, and this heritage is very valuable, and this heritage can tell us great deal about how to handle at least health and well-being. Well-being is something which is again a very mysterious area, which we can again learn from these small tribal societies which are there for the last 5 6,000 years. So what I'm trying to say is that these tribal societies, these so-called simple societies, they have very rich knowledge with them, and this rich knowledge is not just come out in a day or so, but 5 6,000 years old heritage that they have, and this heritage that they have is very very valuable for us, and therefore because it is based on their very rich experience after generations. So therefore, what I'm trying to say that we'll have to, now there is a market of herbal medicine, which is around, must be reaching 2 billion US dollars in India, Indian herbal market. And what is the share of tribal medicines or local medicines? I don't think it is 0.001% even. So therefore, but they are very rich in knowledge, and this can be used in a very rightful manner, like the Guite said, that we have to take care of the IPR, we have to take care of the sharing of the profit with the tribal communities. Thank you very much.
Thank you so much, sir. Dr. Dhal, you
Yeah,
can take over
yeah,
now. Thank you.
yeah. So once again, I'm in the platform. So yeah, good evening all, respected Joshi sir, Professor Getty, Professor Dr. Nadeen, and thank you, Dr. Barsha, giving this opportunity. Sir, I am from CSR, Council of Scientific and Industrial Research, New Delhi. There are 37 laboratories, out of that one is in Odisha. And when I joined way back to 1991, I was assigned by my head of the department to take care about ethnobotany and taxonomy in Odisha. So somehow these tribal medicines and very close to my heart, because I had my PhD on tribal medicine from Navranpur district, one of the most yeah, unprivileged district in Odisha. Now it is improved. So what I want to say, ma'am, most of the things
Sir,
Professor Joshi sir and Dr. Professor Getty have already told. I want to just summarize one of the most important problems and its solutions. Sir, you see, the most important thing in tribal medicines. If we are talking about tribal medicines, we should know that from where we will get biodiversity, first resources, documentations, conservations, take care of the tribal people, then we get the medicines. And recently, we have come across with the COVID-19 pandemic, where there is a guidelines to take the kadha. Kadha is nothing but only from the tulsi, Osimum sanctum, piperum, ginger, and lemongrass. And side by side, and government has also that formulated the that formula to take their curcuma with milk. And recently, friends, people are suffering from dengue, and many of my friends are there allopathy doctors. They suggest to take the juice of the carica papaya leaf. See the demand of the tribal medicines, see the demand of the nature. So my point of telling that, when whatever data we are collecting, we are just publishing some papers, but we have never thought how to come to the market for the benefit of the society. So there are 2 points I want to highlight. One is concept to commercialization, another point is local to global. If you see the local to global, local means the tribal people, how it will come to the national international market. What the most of the things are already explained by my previous speakers. And coming to the concept to commercialization, whatever the concept we have, suppose this plant has a lot of ethnic claims and the tribal people are using, whether they are really using or not, let us have a complete study. Let us have more than 6 7 years complete study, or more than 1 year study. Have a camp or program to their forest area or to the specific forest pockets more than 15 days. Have a crisscross method study. Why I'm emphasizing crisscross method, ma'am? Sometimes what happen, the whatever the tribal friends they tell the users of the plant, they may tell lie also. To verify this, there is a method to crisscross method. Once it is proven that this method is correct, then we have to fill up a questionnaire. Once the questionnaire is filled up, then you collect the plants, go for the drug development program. It needs for the botanist, zoologist, biochemistry, pharmacologist, and medicine people. Then a drug will come to the market. Then that time only we can understand what was the concept by our poor tribal people and how it is being commercialized. And in fact, from the beginning, all the people should be included under IPR, because we are collecting data from them and they should be honored. Without them, we cannot do anything. The moment it comes to the commercialization, then we should think about technology readiness level. In what technology it is there, whether it is a prototype or it is a lab type, or it is a pilot scale study, or how it will come to the market. I will tell you one of the example. I will tell you one example, ma'am. One BGR30 for a drug is an anti-diabetic drug developed by one of our sister laboratory, NBR. Though a lot of medicines are there, still people are using that BGR34 is nothing from the plant products. Many things are there. Only thing that how it will come to the market and how the people will get the benefit. And another one most important thing is that whenever we are thinking about that medicines and biodiversity conservation, side by side, we should take care how to protect the forest, either in situ method or ex situ methods or joint forest management program, and identify some forest pockets where the medicinal plants are grown, rich grown forest pocket area, conserve these areas, identify some RET species, rare endangered threatened species, collect, then go for the drug development program, where some days in somewhere the people will get the benefit. That is only one what I want to say, emphasize, because we are discussing about tribal medicines manufacturers, a lot of knowledge we have. Really, I'm telling you as researchers, all the people those who have joined here, all are extremely outstanding. We have a lot of people, lot of knowledge. Only thing that it should be collective, and we should think that how to come to the market in a form of drug development program, so that society will get the benefit. So this is my message to Barsha and this under this Tell Me Story program. And Barsha, if you are kind permission, if you want, just I will show some of the case studies where I have closely interacted with the 62
Sure.
tribes of Odisha in Kamavit. So, sir, just I
Sure,
will
sir.
go
Go
with
on.
some slides. Fine.
You need to use the present button, sir.
Yeah, just one. Yeah. Is it visible, Barsha? Hello?
Not yet, sir. Not yet, sir.
Not yet.
Not yet.
What is this?
Yes, sir.
Not yet. Huh? Is it visible? Is it
Yes, now
visible,
it is
Barsha?
visible.
Visible,
Yes,
sir?
sir. Yes, sir.
Yeah.
Yes,
Yeah.
sir.
Now it is
It's
visible.
visible.
Yeah. So quickly I
Yes,
will
sir.
go. Quickly I'll go. This is CSR IMMT. Yeah. This is my department. I will not tell because this is not the forum to tell about the department. Yeah. So this is the topics are traditional knowledge for by prospecting a way forward. These all my students are here with me. They have taken a lot of pen to go to the forest to collect the data. You see this, whatever I told you, these are things, sir. And if you go to our Delhi healthcare, leaf 52, the smulla, sugarista, tripola, all from plant products. And just you are telling about the papaya leaf and how that WHO Director General emphasized on the traditional medicines. And the Nobel Prize winners who got the medicines, they are from the on plant for malaria and roundworm. And this I was telling about the NBRA product on anti-diabetics. Then there are 62 tribes of Odisha. Forget all those things are known to all the speakers. I'm not going to tell all those things. Fine, fine. Yeah. Yeah. So these are tribes of Orissa from where I have interacted, tribal of Eastern Ghats.
Sir, the screen is not moving. It's just fixed on the first page.
Or,
CSIR IMMT at a
or
glance.
not
That's it.
moving.
No, sir. We
I
need the
think
next
network problem,
image.
Barsha. Now moving.
Yes, sir. Yes, sir. Yes, sir.
Now moving.
Yes, sir.
Barsha now moving.
Yes, sir. It is. It is. It is.
Yeah. So
Hmm.
leave it. So this is traditional knowledge for bioprospecting, where my students are working and they have visited a lot of forest areas,
Hmm.
and they are the real workers. Just I am presenting their reports. You see, this I have told you. This also I have told you. Our Delhi healthcare, you see, this also I have told you. Nobel Prize winners in medicines, they got that from using Artemisia annua for malaria. This I have told you. There are 62 tribes of Odisha. This already all these speakers they know. I am not going to tell the details. Only case study I will tell because time is very limited time. Please go these things. Yeah. So yes, these are tribals of different forest pockets of Odisha, Eastern Ghats. Yes. So what I want to say, we collected a lot of data for liver hepatoprotective disease. You see, these are diseases for hepatoprotections. These are planned for hypertension. You know, hypertension is a problem for everywhere. Even if I asked a lot of my doctor friends, those who are even if just 20 years, they are also suffering from hypertension, and to some extent, many people are also suffering from liver problem. Those are some of the plants which I want to emphasize. We have collected and published some papers, but it is not come form, it is not commercialized yet to come to the market for a drug form. So this is the most important thing. Plumbago indica, those people are using for birth control. You see, this is the case study. What you are telling the tribal manufacturers. This is a plant I collected from Nabarang, that is Mayurbhanj, the tribal district. The products are used are being sold in different melas and Adivasi exhibition grounds. You see, this is a grass. The products are sofa and cushions. And this
Okay.
also this is a fiber bearing plant. This also you see. As I'm quickly going. This plant is used for ear disease. See, this plant is used for basket making, used in vegetables. See this thing, and oil extraction from Maduka indica, alcoholic beverage, and plates they are preparing. These things, just go ahead. And coming to the tribal medicines, what you are telling, Barsha, you see, if you go for the by prospecting, now government wants in three areas. One is chemical prospecting, gene prospecting, drugs, pesticides, cosmetics, food additives, genetic engineering, crop development, fermentations, sensors, designs, bioengineering, biomodeling. So those are the areas where those taking the clothes from the forest areas or biodiversity forest pockets or tribals areas, this can be enhanced in a form of commercializations so that at least product will come to the market. See, this is a model only how to get a drug from the plant resources. You see this traditional approach: selections, extractions, then fractionations, then formulations, then standardizations, then toxicity, clinical, IPR, final product. So this I want to emphasize. So far the manufacturers is concerned. Some of the practices I want to show. And way forward, if you will say this, taking this tribal medicine manufacture to way forward, then I will emphasize the policy guidelines should be developed in consultation with the local communities. There is a need for synergy among the sectors and departments. What is needed in a common strategy development with the tribal men and women, ensure that the conservation of biodiversity and society of ethnobotany needs to be proactive. Inventory of the work done in universities across India, ethnobotany data should be included in people's biodiversity registers. So those are all my students, and taking their data only I am presenting here. Finally, I want to just give a message to the society, because you will go back to that story. Hard work plus determination plus confidence makes success. Because here we are emphasizing on the tribal medicines, and Barsha, you have rightly pointed out the manufacturers and how the medicine will be manufactured, commercialized, and will come to the market for the benefit of the society. So with this, let me speak. Let me conclude my presentations. I will not take more time. Only thing that I want to emphasize, all the panelist members are here. You see, sir, whenever we are thinking about that tribal medicines manufacturers, at the end I will emphasize the let us think local to global, concept to commercialization, technology radiation level, and if you see the different thematic areas of government of India, out of that one of the most important thematic areas is health and wellness program. So we hope with our join hands together from different universities. Madam is from JNU, sir is from Delhi, Madam is from Meghalaya. Many people are there. Let us join our hands, do something for the benefit of the society. Thank you very much. Thank you. Thank you very much, Barsha.
Thank you. Thank you so much for your valuable insights, sir. We will move on to Dr. Nadeen Pakyntein. Ma'am, the screen is yours.
Thank you. I feel so blessed to be among such eminent experts in social sciences. I mean, scientists who have been part of such good research work, such rich work that you've been doing with tribal communities. And this is a huge opportunity, and I look at it as a learning experience as well. Um, I've had the experience of working with tribal communities in the sense that several projects that I've been involved with. There's one that I worked on teenage pregnancy where I was the co-PI. Another one was traditional health practices, where we actually developed a curriculum, and this was funded by Rosa Luxemburg Stiftung in Germany. And also another one which was funded by SOS Children's Village, whereby we created a curriculum for foster parents into how parenting is and all the different legislations for fostering. And then my other experience was my PhD work itself, which was on the experience of caregivers in taking care of elderly with dementia. So most of the work that I've been done had a little bit of, a little bit of the health perspective as well as a little bit of the social perspective into tribal communities. Now, when I was preparing for this, I wanted to look into tribal communities from the wellness lens, since that is the topic that we've been preparing for all these days. So being healthy is only one aspect of wellness. It is living life to fullest. Wellness is holistic, multifaceted, self-directed, and dynamic, affirming and positive and mindful and inclusive. Again, when we look at wellness, it is about fueling the body, stimulating the intellect, and tending to the soul, are which different components of wellness. Again, if we really delve a little bit more deeper into this, when I say pursuing health, it is also a part of wellness. So sorry about that. The main focus is
It's
actually
complete.
on.
It's okay, ma'am. Continue.
Sorry, I'm still at work. Okay, so when I say that while pursuing health is always a part of wellness, the main focus is actually on living life to the fullest. And the reason for this is that wellness is more than a single aspect of health. And there are, various components to wellness which needed to be considered, especially when we're having this kind of a discussion. Now, the various components that we can consider would be, the physical wellness, mental wellness, emotional wellness, social, spiritual, economical, and also environmental. Now, each of these different dimensions needs to be given careful consideration because ignoring anyone would actually, eventually have a negative impact on the others and also on a person's health. Now, again, if I look at this from the perspective of tribal health, these dimensions of wellness would probably vary from other communities. Now, the components will obviously remain the same, but the way these components are perceived, there would definitely be, a difference from other communities. Now, it has been stated in various research work and articles that tribals live in impoverished communities with little access to healthcare, both in rural and urban parts of India. In my experience, and having been, going to a lot of field work, doing a lot of field work, I actually realized that tribals face a lot of issues when it comes to healthcare services, and usually it is, the tribals in the rural areas who face most of these issues. Now, in comparison to other individuals, tribals bear a tremendous burden of disease. Non communicable diseases, lifestyle diseases are growing in high rates, and several studies have also shown that diseases such as, diabetes, drug use, one that has been mentioned by Sir as well, hypertension, then alcoholism and others, these are some of the few diseases that are actually growing at a very large rate, and it is alarming. Now, certain indigenous groups continue to utilize, different traditional healing methods, which sadly are not supported by our medical system. And that is why one of the reasons as to why we actually decided to work on a curriculum on traditional health practices, because we want traditional healers and the practices to be given, you know, um, what's the word for this? We want them to be recognized for the work. There is a misery that is primarily caused by unfavorable health attitudes and poor socioeconomic circumstances. That is happening, in Meghalaya and other parts of tribal areas in India. Now, the population of tribals is around 8.6%, and there is a lot of trouble in closing the huge healthcare gap between tribal and non tribal populations. The burden of sickness among the tribal population is, in fact, quadrupled by communicable and non communicable illnesses, malnourishment, mental illnesses, addictions, which are exhibited by subpar health seeking behavior. Now, research has indicated a higher incidence of addiction in tribal men, which is very, very prevalent even in Meghalaya. However, tribal women are particularly vulnerable due to the lack of access to maternity health care. Now, again, an expert committee has been, formed, and they had made, recommendations to respond to this growing demand, and with the ultimate goal that they want to close the current disparity in indigenous people's health status by at least 2027. My question is, would this be possible? Again, my other question that comes to mind is, if one is saying that health seeking behavior is lacking among tribal communities, what are the reasons for this? Research has shown that there are still many tribal areas that struggle with access to healthcare, resources, quality education, and the experience in the field that one had during, I had during my data collection and fieldwork with students has confirmed the struggle that tribal communities have, especially in rural areas. In fact, if I tell you of one example, there are areas that are so secluded that there is not even a proper road for us to actually access that village. Now, it has also been stated that tribal people are not included in the country's mainstream socioeconomic activities, which has resulted into, lower economic attainment, lower educational attainment. The lives are frequently characterized by a lack of material resources and has restricted access to public transport, education, healthcare, and education. Now,
Dr. Nadeen, you're frozen. The screen is
okay,
frozen.
all right. Yes, yes. In addition, global health research and on tribal communities is just as poor. Now, we're talking about this treatment gap again and again, and we know that is something that, that is huge. amongst tribal communities. So let me shift this lens again to social wellness of tribal communities. Now, tribal communities function by the relationship that we have with each other. We have close relationship, we have kinships. They usually live together in the same geographical area, but due to various factors such as unemployment, globalization, education, and others, today most tribal communities, individuals, have migrated to other parts of the country, and this in turn has led to the disintegration of tribal values, morals, and practices. Now, if we are to look at this from the social wellness lens, we would realize that this slow disintegration of our tribal communities, which in turn has started to impact relationships among tribal individuals and communities. Several social issues have become rampant within tribal communities, such as land rights, displacement, exploitation of resources, lack of education, lack of healthcare, erosion of culture and tradition, economic marginalization, political marginalization. There are also issues of divorce, separation, single parenthood, addiction, child abandonment, poverty, and the list goes on and on. Protecting tribal communities would require a comprehensive and holistic approach that would cater to sustainable development, access to education, healthcare, and empowering tribal women, livelihood promotion, protection of our land rights. So I leave you with this thought. If we are to cater to tribal communities and look into the wellness aspect of these tribal communities, are we doing enough to protect our communities, their indigenous knowledge and systems, instead of imposing on them what should be done and what should not be done? We need to change this existing approach into what we can learn from tribal communities, what practices that tribal communities are doing that could be strengthened, and what we can do to support the wellness of tribal communities. So, probably our entire mindset would transition from a they approach, rather, towards more of an us approach. Thank you.
Thank you so much, Dr. Nadeen. Uh, we will now move on to the question and answer session. My first question is for Professor Guite. Uh, Ma'am, from your experience, could you shed light on some of the lifestyle practices that effectively contribute to the welfare of families possessing children with special needs within tribal communities?
Uh, yeah, Barsha, like what now Dr. Nadeen has talked about in terms of the kind of problem which is the tribal communities are facing in terms of burden of disease and also from the social wellness lens. So here I would like to just point that like from my own experience and the lifestyle practices when we talk about lifestyle practices as such, because as I say, tribes of different regions of India carry a very distinct characteristics, right? And our lifestyle practices are determined by our social economic conditions, our living conditions, and then our propensity to afford for a better living standard, for education, and all. So, all that social, I would say, economic status, the social determinants of health determines the lifestyle practices. So, a tribal of, let's say, tribes of Northeast India or a tribes in, let's say, Orissa or in Chhattisgarh, so that depending on their practices, how do they deal with those uh, families or the welfare of the families who are possessing children with special needs? So I actually find the questions to be very broad for me to answer. But if you ask me specific to my experience of my region, so there I can maybe throw some light on it when like if we see the kind of literacy rate in terms of the all India average and also the percentage of the scheduled tribes, uh, there is a gap. As per I think 2011 census, and also as per the NFHS reports and all, we have been seeing the trends in like from NFHS 1 to 5, and then the latest reports. So we see that there are this kind of uh, gaps from the all India average to the average of the 7 tribe population. So in that context, uh, to me, it's difficult to comment as such of the tribes in general of in the Indian context, but regionally, uh, like from my experience, I feel that uh, when it comes to institutional interventions in tribal region, then because these are children with special needs requires a professional set, or let's say a special set of skills and knowledge. So institutionally, you need a professionals who have those kind of trainings, and then those kind of institutions are absent, totally absent in the tribal dominated regions. And but when we see in terms of uh, the kind of how society look at children with special needs, uh, since there are no, or let's say no or less awareness about it, so sometimes there is this saying that ignorance is a bliss. So there is no such kind of stigmatization, or you kind of outcast the family or the parents who has a children with special needs. I would say no stigma attached to that, and no abandonment which is done by the families. But it is a sad situation that there is no government run institution. Collectively, there are philanthropic organizations which comes out, maybe some non-government organizations or an associations of the tribal groups, or maybe the church or religious groups taking the initiative. So this kind of institutional mechanism that we can see in my experience from the region where I come from. So yeah, that's what I can say as well.
Thank you, ma'am. My next question is for Professor Joshi. Sir, in your article, Psychotherapeutic Elements in Shamanistic Healing in the Context of Himalayan Tradition, you have mentioned about shamans or people gifted with the art of carrying out exorcism. How deeply ingrained are these beliefs in indigenous communities, especially within the context of treating psychological issues? How can modern psychological associations integrate this traditional art within mainstream society while simultaneously ensuring the prevention of any disregard towards these practices? So, sir, you are muted.
Okay, you have asked a question which is very dear to my heart, and I'll try to answer this question. I think I told you that there is an empirical side of traditional medicines. There is also supernatural or magico-religious side of traditional medicines. Now, this is something, like I must tell you, in India, psychiatry or art of psychiatry or science of psychiatry, whatever you may call it, is very hard to access, because most of the psychiatrists, they are concentrated in urban areas, in the industrial and urban areas, and the rural areas and tribal areas almost are, there is an absence, largely absence of psychiatrists. So they do not get psychiatric, consultation, counseling, or treatment. Now, a community which is not getting psychiatric consultation and treatment should have gone crazy by now, because they don't know the scientific way, but they are surviving. So there must be something there, that in the absence of psychiatrists they are living like the sane people. They must be doing something. Now we don't know, as I tell you, that they also have a heritage of dealing with mental illnesses, and this heritage again is very old, and this heritage again is undiscovered. We have not yet known fully about it. We simply say that this is all numbo jumbo. They have they like believe in unimaginary things, and therefore this should be discarded, abandoned. But we don't have psychiatrists to provide services to them. think this is a very catch-22 situation that we have. Now they are having shamans, They are having shamans who are male shamans, female shamans. They have oracles, they have sorcerers, they have magicians, they have witchcraft specialists. All kinds of things are there. There is no universal or pan-Indian situation. Different communities have their different system. But what is there are two things, and I think one of the very leading scientists was Sudhir Kakkad, who really tried to investigate this side of, at least from the psychotherapy point of view, psychoanalysis point of view. Now, what we see here is that there are mental diseases, mental illnesses are randomly distributed. It's not that mental diseases are there because in tribal areas, what is happening? They are rapidly changing, like Dr. Nadeen told. They are rapidly changing. So when a community undergoes a rapid change, mental illnesses suddenly shoot up. Then we have got again all kind of dispossessions that is going on in these areas. People are being dispossessed from their land, their rights are being curtailed, and thirdly, there are conflicts in many of these tribal areas. So therefore, there are causative factors are there. Now, how are they dealing with it? And especially the diseases which are of mental nature. So I think they have these shamanistic traditions. This shamanist tradition is a very old tradition. We don't know how old this tradition is, but in shamanistic traditions, what happens is that as against psychiatric treatment, psychiatric treatment is based on two principles. One is individual privacy. So you have to go to the privacy of a psychiatrist. But the treatment in the communities by the shamans is of different. It's almost opposite to it. It is public and it is social. So you have all this treatment that goes on in the public. So there is this cathartic kind of a thing that emanates from there. So again, what I'm trying to say is that if you read my articles, if you read, for example, I have said in my this article that you mentioned, I've said even becoming a shaman is a therapeutic activity. You become a shaman because you overcome a mental distress, and therefore you become a shaman. So what I'm trying to say is that they have a very rich knowledge. And again, as I said, that the psychiatric textbooks are based on again social fabric, which is a Euro-American social fabric. We have to enrich Indian psychiatry also. If you understand Indian social fabric and utilize Indian social fabrics, and the way some of the things that people are doing, because what you do in a psychiatric treatment, because I've worked in a psychiatric hospital also. In a psychiatric treatment, when a person is healed by medicines, he or she becomes a vegetable. But when a person is healed in tribal communities through shamans, he is as agile and as vibrant as he was before. This is the basic difference between the treatment there and treatment here. I think we have to learn a lot from this science of ethnopsychiatry, which is prevailing in different parts of
Thank you so much, sir. My next question is for Dr. Dhal. Sir, you already mentioned about all the research going on regarding medicine, ethnomedicines. So, could you
Yes.
suggest some of the steps that the government might undertake for the integration of ethnomedicine within the mainstream society?
Yeah, yeah. So thank you, Barsha. As already I have told you during my presentations, whenever the question comes about ethnomedicines, we just think about that the theme concept to commercialization. How the concept will be commercialized and will come to the market, to the society as a drug form. So my that suggestions that if we are really interested to have some ethnomedicines for the benefit of the society, let us try to find out that where it grows, conserve the areas, protect the areas, collect the informations, document the data. And as you know, when we are going to collect the bioactive molecules for drug development program, bioactive molecules are not in the same throughout the all seasons. Whenever in which plant the bioactive molecules are more, that also we have to see it. Then we collect the plants and go for the phytochemical screening, go for the analysis, then come out with a drug form. So my only submission and that suggestion is that if we are interested to come out to a drug form, those are the steps to be needed either in the R&D line or in the academy line, so that and so that everybody will be interested to collect the data and have in mind to come out to a product firm which will help the society. And it is not that only single man can do it. A lot of principles, a lot of policy had to be done it, and not only government. As I told you in my presentations, as a man also we should think that if we are just Dr. Nadeen madam was emphasizing, if really we want to do something for the society, at least in our sector also we can start. Because if today we are not going to start, tomorrow the same thing we may not get the same thing. Because under climate change many things are going to be changed, and many things are going to be disappeared, and many things are going to be rare also. So if today we are thinking, let us do something, and I already mentioned in my way forward slides how to take in an active mode, so that from the concept whatever we are today we are conceiving, tomorrow it will be commercialized in the form of product or in the form of something for the benefit of the society of our own people. So side by side, what Joshi sir emphasized that we should protect our heritage, we should protect our nature, we should give respect to our tribal friends, give respect to the natures, and side by side, if we are cutting the plants, we should go for plantation also, not for the deforestation also. Afforestation also required. So side by side, everything should be balanced. In the balanced mode, we should think about how a data can become and how the things come for the society development, either in a product form or a drug development program or a technology or a process development or any other things, so that society will get the benefit. So only my suggestion is that let us implement some recommendations for the benefit of the society. Thank you, Varsha.
Thank you so much, sir.
Yeah.
Dr. Nadeen, my next question is for you. As you mentioned that there are several issues regarding teenage pregnancies among the tribes. Now, the mainstream society usually views such pregnancies from a very derogatory point of view. So, what is the tribal societal outlook towards teenage pregnancies? Do they have any awareness measures or indigenous contraceptive methods to prevent the same?
Okay, thank you so much for your question. All right, so if we're talking about, teenage pregnancy and how our society here in this part of the country looks at teenage pregnancy, it is, we look at it more of, it's not something that we shun off or something that we looked at a very negative way. In fact, if teenage pregnancy has happened in our society, we find that parents are actually, the first reaction would be, being angry and scolding the adolescents. But then after a period of time, the study that I had done with Dr. Mawabiang, we realized that over a period of time, parents actually accept, the adolescent that has become pregnant. And, as a consequence to this acceptance, they actually start to cohabitate. So in our culture here in Meghalaya is that we find that this, especially in rural areas, if a boy and a girl below age of 18 years also, if they've had, consensual sex, and the girl had actually gotten pregnant out of this, we actually, after a while of, scolding or trying to teach them what is the right way of going about with, teenage pregnancy and all that, but, we start to accept them. And as soon as they cohabitate, we consider them as husband and wife, actually. And after that, the only, sad thing that we find in our study is that as soon as they find out that they are, the girl is pregnant and the boy also has gotten the girl pregnant, they have to leave their school, they have to stop education. The boy will have to start earning, to be able to afford the expenses of having a child, and the girl will also have to stop going to school. Now we realize that as the years pass, because families are actually quite supportive, after they have the child, they would then they would then actually later on, if allowed, if they come from a family which is a well-to-do family, this young boy and young girl may go back to, their education, try to finish off what is left at a minimum level, and then, go on with life. but then they have to start working, they have to start being responsible for, the new baby that they've brought into this world. So that is, the outlook that we have in our tribal community here in Meghalaya with regards to teenage pregnancy. Now, again, if we look at it from in terms of the question that you asked about, what we do in order to, uh, not have the second, I think it was the third part of your question with regards to
Yes,
the,
ma'am.
the materials.
Contraceptive.
Can you just reiterate the question again?
Yes, yes, yes. Do they have any awareness
Will you-
measures or indigenous contraceptive methods to prevent the same when
Mhm.
teenage pregnancy?
Okay. So, with regards to the awareness measures, uh, because of POXO Act, all the districts now under the state child protection society, they've been mandated and they are responsible to creating this awareness. And in fact, the study that Ma'am Marba and I had done we've turned it into a report, and this has gone into all the different districts as well. And we are trying to create more awareness on teenage pregnancy and what are the drawbacks of teenage pregnancy. And we also speak about POXO, the POXO Act, and how it criminalizes such cases. But just to add on to this is that the difference in our part of the country in in Meghalaya is that we find that teenagers have consensual sex. POXO Act talks about non-consensual sex, right? So the penalizing actually, when it happens to the boy who has gotten the girl, pregnant, it's not really something that we would accept here. But since it's part of our our act, the POXO Act, we have to go with it. And because of this, actually, we're just driving away from the awareness aspect, but because of this, now we find that yes, the the girl has gotten pregnant, the boy has gotten the girl pregnant, okay, fine, but because the fear of POXO, awareness programs are going on, so everybody is becoming more and more aware of POXO Act, and then that the fear is instilled in them. Now when we talk about prenatal this treatment, care for young mothers, that is becoming lesser and lesser because young girls are getting scared of going to hospitals, because they think that if they go to the hospitals, the doctor has to talk to the police and inform the police that this case has happened, so that the fear that is going on, that is actually not really helping. So that is something that we've been talking to the government also, if we can change the POXO Act a little bit from looking at this from the perspective of our tribal communities here in the Northeast. And then with the last part of your question, I think you spoke about, the contraception that we use. I'm not sure if there is any herbal medicine that we are using here in Meghalaya, but I do know that the only way of, not of using these different types of contraception was is only abstinence from sex and withdrawal after, before ejaculation. These are the only known ones that I am aware of. Now, with regards to using any sort of herbal medicine, I'm not sure.
Okay, ma'am. Thank you so much. Uh, with that, we come to an end to tonight's discussion. I thank each one of you for sharing your knowledge and valuable insights with us. I'm sure our audience has had a wonderful time and have learned a lot as well. We are grateful to all for taking out time of your busy schedules and for being a part of this discussion. It was an absolute pleasure to have been here in your company this evening. This is to remind that we are calling for submissions on tribal history and tribal representation in history, the details of which can be viewed on www.tellmeyourstory.biz. Good night, everyone.
Thank you.
So we'll
Good
take a
night.
leave, Barsha.
Ma'am, sir, you can take your.
We'll take a
Yes,
leave.
sir. You can take your.
Namaste,
Thank
namaste,
you
ma'am.
so.
Namaste.
Yes, sir.
Namaste.
Thank
Namaste, ma'am.
Thank you so much. Thank you so much.
Thank you so much, Ma'am Barsha.
Yeah.
Thank you so much, Sir Dhal. Bye
Thank you,
bye.
Yeah.
ma'am.
Thank you.